eating. So let me begin by answering that question. The kidney clearly more important than the heart, okay? But anyway, so our talk. Okay, we'll give the cardiologist a chance to rebut that at some other time. So taking the kidneys to the heart, we're going to talk about managing chronic kidney disease-related anemia with a new class of drugs that may soon become available. So again, these are my disclosures. I have really nothing relevant to disclose regarding this presentation. So our learning objectives for the talk are, first of all, to kind of clarify the disease burden imposed by untreated or unmanaged anemia in patients who have chronic kidney disease, to include issues related to racially diverse populations. We're going to correlate the pathophysiology of anemia in chronic kidney disease with our various therapeutic targets, and identify appropriate candidates for emerging CKD-related anemia treatments among patients on or not on dialysis based on efficacy and safety data from recent clinical trials. So as with our first presentation, we're going to have some pre-test questions, and then we'll follow that up at the end with the post-test questions. So let's see how you do here. Okay, a 2022 study by Whitbrodt found that patients with anemia and chronic kidney disease at baseline had higher rates of hospitalization for which of the following cardiovascular-related events as compared to patients with CKD and no anemia? Is it acute coronary syndrome? Is it heart failure or stroke? So go ahead and choose one of those answers now. Okay, so it seems that most people have chosen either acute coronary syndrome or heart failure, but there clearly seems to be a predominance of heart failure, not many takers on stroke. So we'll see how we go towards the end. Next question. Okay, erythropoiesis stimulating agents, so-called ESAs, and emerging hypoxia-inducible factor prolyl hydroxylase inhibitors, PHIs, they exert their therapeutic effect by addressing which one of the pathophysiologic processes of anemia? Is it accumulation of uremic toxins? Is it decreased erythropoietin levels? Or is it reduced renal clearance? So go ahead and choose one of those answers now. Okay, so most people are choosing decreased erythropoietin levels, not many takers on accumulation of uremic toxins, and maybe a smattering of reduced renal clearance. And our last question, in clinical trials with hypoxia-inducible factor prolyl hydroxylase inhibitors, something that we're going to talk about in this talk, in the trials of these new drugs, they demonstrated cardiovascular safety that was non-inferior to erythropoietin stimulating agents in patients with either dialysis-dependent CKD or non-dialysis-dependent CKD. So we're asking which one of these was actually shown to be non-inferior, okay, to ESAs. Was it daprodustat, roxadustat, or vadadustat? Okay, so most people are choosing daprodustat with kind of an equal amount for the other two. As you will soon learn, and as indicated in this question, this class of new agents are the dustats, and they all have varying first syllables. Okay, so let's begin by, first of all, talking about an overview of anemia in chronic kidney disease. First of all, as you well know, chronic kidney disease is actually quite prevalent in our population. It's estimated that about 15% of adults in the country have some element of chronic kidney disease. Unfortunately, up to 90% of these individuals are undiagnosed. There's been a move to perhaps employ better screening methods for the detection of chronic kidney disease. As you well know, the most common way we screen for chronic kidney disease is obtaining a serum creatinine concentration, and from that we have estimation formulas that kind of give us an idea of the glomerular filtration rate. But to provide even better screening, it's being advocated that maybe we ought to be screening the urine for albuminuria, and so we're going to see that probably really take off here in the future. 40% of those with chronic kidney disease who have more severe reductions in GFR are even undiagnosed. So again, there's really a need to perhaps identify people earlier, particularly since we have a lot of new emerging agents that have been shown to have favorable effects on kidney disease progression. On the left-hand panel, you can see this breakdown of chronic kidney disease among various subgroups, again, men and women. Chronic kidney disease is clearly more evident in people as they age, particularly because comorbidities have likely been present for a longer period of time. And again, you can see it broken down according to various racial subgroups. Anemia is definitely something that we tend to see more commonly in patients with chronic kidney disease because, as you well know, the kidney is the main source of erythropoietin, which plays an integral part in the maintenance of a normal hematocrit. And as people start to get worsening chronic kidney disease, reduction in kidney mass, anemia becomes much more prevalent. So in this particular analysis, 23% of patients with non-dialysis dependent chronic kidney disease, stage 3A to 5, had anemia as defined as a hemoglobin of less than 10. And that prevalence of chronic kidney disease went from 18% at stage 3 up to 72% at stage 5. And on the left-hand panel, again, the increasing green bars are those people who have hemoglobins between 10 and 12, clearly anemic. You can see how it's increasing along the stage of chronic kidney disease. Whereas the blue bars, they're declining. Those are the individuals who have a normal hemoglobin. So again, loss of kidney mass, not surprisingly, becomes more commonly associated with anemia, primarily because you're reducing erythropoietin production. Now, one of the problems of anemia is that it does affect various qualities of life. So in this particular analysis, you're looking at questionnaires that assess the well-being of an individual. And on the right-hand panel, you see a questionnaire related to work productivity. And what you can see when you look at the various breakdowns of this questionnaire, the sense of well-being is decreased in those individuals who have anemia. And on the right-hand panel, the work productivity measurements are less in those who have anemia. So again, it affects the quality of life. That's been pretty uniformly found in various measures of anemia, that people don't feel as well. They tend to be a little less productive in terms of work. There's an impact of anemia on the risk of hospitalization in patients with chronic kidney disease. Obviously, that's related to our first lecture. So in this particular analysis, a lower hemoglobin concentration was associated with a higher risk of hospitalization. It was particularly evident in those who were non-dialysis dependent, who had a hemoglobin of less than 10. You can see the odds ratio, 1.46. But even in dialysis-dependent CKD, Those that had hemoglobins between 10 and 12, again, the risk for hospitalization was slightly higher. So again, particularly related to our first lecture, anemia is associated with an increased risk of hospitalization and also the length of stay within the hospital. Anemia is associated with long-term health outcomes that are detrimental. For example, it's been associated with the development of impaired cardiac functions, predisposing to volume overload and heart failure hospitalizations. In the middle panel, again, this reduction in hospital or quality of life measurements, and on the right, increased hospitalization and mortality. So again, it's a laboratory finding that has true meaning in terms of the clinical relevance. The symptoms of chronic kidney disease-related anemia are not surprisingly on the left-hand panel. People will tell you they feel a little bit more tired, less energy. A lot of these are obviously nonspecific, but nevertheless, you can tie them in many instances to the underlying hemoglobin concentration. People will develop shortness of breath with less activity, difficulty remembering things. The impact of anemia on chronic kidney disease can also be detected by inability to stand for long periods of time, decreased sleeping, lack of motivation, feeling distress, feeling burdensome. So again, these are obviously nonspecific, and many things can cause these types of things, but nevertheless, in various surveys, you can tie these to reductions in the hemoglobin concentration. The associations between the risks of CKD and CKD-related anemia can have relevance to underlying race and ethnicity. For example, kidney disease, first of all, the most common cause of kidney disease in our country is from diabetes and hypertension. And when you have diabetes, for example, the risk of developing kidney failure does have a genetic component. And what I mean by that, Black individuals tend to have a much higher risk for kidney disease than do whites. Kidney disease is more commonly present in Hispanic versus non-Hispanics, and also a higher risk in American Indians. And these susceptibilities have been shown even when you factor for things like glycemic control, blood pressure control, suggesting that there's some sort of genetic susceptibility. Black individuals are found to have less transplantation and less referral for home hemodialysis. And so, in other words, there are treatment disparities that we deal with in our patient populations. And CKD-related anemia tends to be much more commonly present in non-Hispanic and Black individuals as compared to members of other racial groups. Again, highlighting the idea that there may be racial disparities in the way that we administer the various tools we have for medical treatment. So how do we manage anemia in our patients who have CKD? So this is just kind of a slide illustrating some of the underlying causes. In CKD, blood loss is obviously a potential cause of anemia, but one of the big drivers of anemia is inflammation. It turns out that as you lose kidney function, various measures of inflammation start to become much more prevalent. And any kind of inflammation can lead to iron reutilization defects and predispose one to anemia. Reduced clearance, again, the greater the reduction in GFR, this inflammation increases. And one of the factors that is related to inflammation is a protein called hepcidin, and I'll talk a little bit more about that. But that's a protein that accumulates in the blood that can contribute to this iron reutilization defect. As people lose kidney function, a variety of uremic toxins begin to appear, and it shortens red blood cell lifespan. And again, on the far right-hand panel, this reduction in erythropoietin production is a big player in the development of anemia. The blood loss, this inability to adequately utilize the iron in the body, again, further contributes to decreased red blood cell production. And the way we address currently the anemia is the administration of exogenous erythropoietin-stimulating agents, so-called ESA. We give iron whenever we think people are iron deficient. And then what we try to avoid, obviously, is transfusions, only because if we want to get people prepared for transplantation, we want to minimize any kind of antigenic stimulation that might come about by transfusions and those kinds of things. So how do we diagnose this? Well, this is the guidelines and the recommendations from a major advisory board called KDIGO. So what they say is that we need to monitor the hemoglobin periodically as part of our maintenance and part of our routine evaluation of CKD patient. Obviously, if the hemoglobin is stable, one can just monitor them periodically. On the other hand, if the hemoglobin is reduced, again, it's important that we treat the anemia, determine its underlying cause, and treat it accordingly. And that may either involve iron therapy if they're iron deficient, or giving them an erythropoietin-stimulating agent. The diagnosis of anemia in CKD, if you're more than 15 years of age, according to this organization, would be a hemoglobin of less than 13 in men and less than 12 in women. And then in younger people, less than 15 years of age, the values you can see are a little bit less. The recommended evaluation should be a complete blood count, a CBC, a reticulocyte count, a transferrin saturation, and if you think it's warranted, B12 and folic acids. So for example, if the MCV, the mean corpuscular volume, was high, or the patient was at risk for these deficiencies, you would want to go ahead and make sure you measure that. And then address the correctable causes of anemia, the deficiency, any kind of inflammatory state, to the extent that you are able to correct those before we initiate the erythropoietin-stimulating therapies. And when we give iron, it turns out that this is really true in dialysis settings. We like to give it oral or intravenously. It's a much more effective way to give iron. And we're doing that actually more so even in CKD patients. The oral iron is a lot less, is poorly tolerated in many instances, and the absorption is, somewhat hard to bring about. Just to remind you, remember, it's the reduced form, the iron 2+, that's primarily reabsorbed, not the oxidized form, which is 3+. That's the whole rationale by which you sometimes administer vitamin C when you give iron. You try to get the iron in the reduced form, which enhances its absorption, which occurs primarily in the early part of the small bowel, the duodenum, the initial part of the small intestine. Okay, well, the standard of care, again, if we look at erythropoietin-stimulating agents and iron supplementation as they exist today, they work, but there are some challenges with these. A lot of people who are given erythropoietin-stimulating agents are very poorly responsive, primarily when they're inflamed, okay? And again, the problem with iron absorption is a real issue. The have to give them, on dialysis, we give them IV, or you give them sub-Q in the outpatient CKD setting. And again, we try to avoid transfusions whenever we can. The iron, as I mentioned, can be poorly tolerated when given PO, and so we're trying to give a lot more of this iron IV whenever possible. One of the things that I'm going to mention to you here subsequently is one of the problems with the erythropoietin-stimulating agents is that if you try to normalize the hemoglobin, it's actually associated with worse outcomes. That's one of the things that we've learned now over the years. So our goals are actually lower with advanced stages of CKD. We don't try to bring the hemoglobin back to normal. And the problem with iron, of course, is you can get iron overload. There's some literature that suggests it might predispose to infections. That's kind of controversial. And rarely some of these IV iron formulations can cause anaphylactic reactions. That's much less common now with newer preparations. The ESAs, there's an issue with storage. Sometimes you can get these antibodies that neutralize their effect. And obviously, iron, when you give it IV, requires IV access in transfusion clinics. Okay, so the idea that we no longer try to normalize the hemoglobin really came from these three studies that are illustrated here. You know, you would think, gee, you give erythropoietin-stimulating agents, if you normalize the hematocrit, the patients would do great. But what was found when this was actually studied in 3 trials, one called the normal hematocrit study, done a number of years ago, and then 2 randomized prospective trials called Choir and Treat, what they found was that when you compared in these individuals who had chronic kidney disease, if you got to near normal hemoglobin levels as compared to a lower goal, there's actually worse mortality as measured by either all-cause mortality, non-fatal MI, hospitalization for heart failure. There was a higher risk of stroke, and myocardial infarction. So because of these adverse outcomes, the erythropoietin-stimulating agents, had placed on them black box warnings that you needed to have a lower goal. And in fact, we now try to raise the hemoglobin concentration really no higher than 12 or so in our CKD populations or even in our dialysis populations. That is, there's detrimental effects when you get to near normal values in this patient population. What's not quite clear is it because is it an effect of normalizing the hemoglobin per se, or is it an effect of the erythropoietin stimulating agents themselves that were responsible for these adverse outcomes? And that's again something that's debated, I think, still in the literature, but it has raised the specter, might there be better ways to correct the anemia beyond what we are currently doing? So, shortcomings in current treatment practices. I just wanted to highlight these 2 studies, one by Wong. He did a prospective cross-sectional analysis of data from nephrology clinics in several to include the US, and what he found was, despite what's currently being recommended, hemoglobin is measured much less commonly than what should be, and more importantly, that even when anemia is discovered, it's rarely treated to what is currently recommended, a value of between 10 and 12. This study by Wintrop in 2021, again, a retrospective look at claims data, once again, finding that less than 0.1% of CKD-related anemia received any kind of iron supplementation, and only about 2% or so were actually being treated with erythropoietin-stimulating agents. In other words, despite either patients aren't, physicians aren't really measuring the hemoglobin concentrations as they should, or when they're found to be reduced, they're not really addressing the issue in many instances. And the impact of addressing this issue, inadequately treating anemia on health outcomes, again, in this analysis, showing that there is, on the left-hand panel, an increased risk of heart failure hospitalization. So you might take note of that. Increase in heart failure hospitalizations in people who have inadequately treated anemia. Not seemingly much difference in acute coronary syndrome or stroke hospitalizations. On the right-hand panel there, you can see that when you compare people who have anemia versus those that not, the risk of developing further progression in CKD, the rate of GFR decline is faster and greater. There's anemia as a contributor towards CKD progression. So again, that's another issue with regards to not treating it. So what are some of the current barriers to the adequate treatment of CKD-related anemia? Well, as I mentioned, the vast majority of these individuals are not being treated with either IV iron or erythropoietin-stimulating agents, despite the high prevalence of the disorder. Some of the Barriers include concerns about cardiovascular safety. These 3 trials that I alluded to, have really, most people are aware of them and they're a little bit reluctant to treat because of the cardiovascular safety. The difficulty in administering parenteral therapies, again, prior to dialysis, you have to give it sub-Q, you have to teach the patients, they have to be able to do it at home or come to a clinic. The potential lack to access to therapies, the necessity of follow-up, or even underreporting. So these are some of the barriers that exist for treating this disorder. So what's new on the horizon? And that's what I'd like to focus on here in the remainder of the time. So remember that one of the most important factors that regulates the production of erythropoietin is a protein called hypoxia-inducible factor. This is a protein that's within the body that becomes upregulated anytime you're in a hypoxic environment. And it leads to the production of other proteins that defend the body and make it adjust to a hypoxic environment. And you might predict that if you had less oxygen, it would make sense that you would like to produce more erythropoietin, which would then increase red blood cell mass, increase your oxygen carrying capacity. So hypoxia-inducible factor is highly regulated by the oxygen environment, and it stimulates erythropoietin production. And one of the things that regulates this hypoxia-inducible factor protein is another set of proteins called prolyl hydroxylase domain inhibitors, okay? And I'll show you how these work in just a second. So hypoxia-inducible factor is a master regulator of oxygen homeostasis. It transcribes various genes that allow the body to adapt to a low oxygen environment. Increased EPO production in the liver and the kidney is under the influence of this hypoxia-inducible factor, as is various measures of iron homeostasis. The PHD enzyme is an enzyme that catalyzes the hydroxylation of hypoxia-inducible factor, leading to its degradation. The way this system works, the HIF protein, unfortunately I don't have a slide to show you this, but it is composed of an alpha and a beta unit. The beta unit is always transcribed, it's always around, but the alpha unit is very sensitive to whether there's oxygen present or oxygen lack. When oxygen is plentiful, these prolyl hydroxylase domain enzymes, they hydroxylate that alpha chain, and once it becomes hydroxylated, it gets degraded. In other words, when you have lots of oxygen, there's no need to stimulate erythropoiesis. On the other hand, if you're in a hypoxic environment, this PHD enzyme now becomes inactive. And so now this alpha chain can bind to the beta chain, and it stimulates now transcription of erythropoietin. So it's all dependent upon this oxygen and regulation of these PHD enzymes. Interestingly, there are published data that in Colorado, for example, dialysis units, they have to use less erythropoietin stimulating agents because the hypobaric hypoxia of altitude in Colorado actually stimulates some endogenous erythropoietin enough that EPO stimulating therapies, the necessity and the doses are less. That's published data. This is the whole basis by which climbers that go to high altitude get increases in their hemoglobin concentration, because hypobaric hypoxia becomes a major stimulus for erythropoietin production. Okay, so with that physiology in mind, it was postulated that if you could develop a drug that inhibited this prolyl hydroxylase domain protein, PHD, in other words, mimic a hypoxic environment by directly pharmacologically inhibiting the PHD protein, now you would allow the HIF alpha and the HIF beta to dimerize and allow it then to go on and make erythropoietin production. So that was the whole rationale behind developing what are called PHD inhibitors, okay? So it all pH prolyl hydroxylase domain inhibitor will allow HIF to dimerize and make EPO. And so what this shows is that when you give these PHD inhibitors, you get increased EPO production primarily from the kidney, but there is also some being produced by the liver. The other thing, again, just remember this HIF activation also affects iron homeostasis. So what it also does is it causes upregulation of a protein along the GI tract to facilitate absorption of iron. Okay? In addition, by stimulating the EPO, now it causes increased red blood cell production. And the increased erythropoietin protein has an effect to downregulate this other protein called hepcidin. Hepcidin, shown here, works against you and contributes to anemia because it traps iron inside the enterocytes along the GI tract. What you see here is hepcidin upregulates this protein called FPN. It's called ferroportin. This is a necessary protein to get iron out of the intestinal cells. So when you're inflamed and hepcidin levels are high, any iron that crosses into the enterocytes along the GI tract get trapped in those cells. It can't get out into the blood where it needs to be ultimately delivered to the bone marrow. So when you give the PHDI inhibitors, EPO goes up, and the high EPO kind of downregulates, now allowing more iron to be absorbed. So what's been observed is with these PHD inhibitors, you don't need to give a lot more oral iron because the normal iron that's contained in the diet is absorbed much more readily, and the iron that's within the body is now utilized to a much greater extent. So this seems to be a much more physiologic way to treat anemia as compared to just giving exogenous EPO by itself. It's very physiologic. You're using the own body's apparatus to cause release of erythropoietin. Again, we don't have a slide to show this, but just imagine when I give a dialysis patient a dose of erythropoietin, you can imagine there's a huge increase in the blood level as I give it IV, and then it trickles down. What happens with this drug is the EPO levels in the blood go up very, very slowly. It's very slow rise and then a slow continuous production of red blood cells. It's much more physiologic. And that was the excitement about these prolyl hydroxylase domain inhibitor drugs. So there were 3 of these that have been actively studied in clinical trials. They're called the DUSTATs, roxadustat, vadadustat, and daprodustat, okay? And they were conducted in trials looking at both pre-dialysis CKD patients as well as people who were on dialysis. Well, roxadustat did major clinical trials. You can see they all had these names reminiscent of mountains, Olympus, the Andes, the Alps. These are all the names of the trials. And I'll show you some of the results of those. But ultimately, when they applied for approval by the FDA, it was rejected. And I'll comment more on that. Vadadustat, they had a series of clinical trials called Innovate and Protect. Again, either pre-dialysis or on dialysis, found to be quite effective in correcting the hemoglobin. And then in March of this year, again, rejected by the FDA. And the most recent one, daprodustat, have a series of trials called the Ascend trials, a whole family of these trials. And they're the one that is still remaining out there. They have their decision pending, okay? So we're kind of waiting on that particular one. So if we look at summarize the trials, roxadustat, vadadustat, daprodustat, all 3 of them, they're very effective in increasing the hemoglobin. They've been shown, and the design of the trials was to show that they were not inferior to the currently available erythropoietin stimulating agents. They all reduced the number of red blood cell transfusions that would be required. Adverse events were comparable to placebo or erythropoietin stimulating agents. But cardiovascular safety is where the FDA raised a concern with the roxadustat. I will tell you that there was a signal, there was increased vascular access thrombosis in the dialysis patients. With the vadadustat in their non-dialysis CKD, again, there was a concern of cardiovascular safety. And that's what led to those drugs being rejected. Again, in the trials with the daprodustat, they seemingly had no evidence of adverse cardiovascular outcomes as compared to their comparators, so that's why they're still in the game, if you will. This is looking at the one that's still out there, daprodustat, in their ASCEND trial, and here you're just looking that when you give it, by the way, you just give this drug once a day orally, it's a pill, as it's no injection, you can raise the hemoglobin in a comparable fashion to the erythropoietin stimulating agent. And on the left-hand panel are the non-dialysis dependent subjects. On the right-hand panel are the dialysis dependent subjects. So again, comparable response to raising the hemoglobin, one with an oral drug once a day, the other with a subcutaneous injection. The major adverse cardiovascular outcomes, again, no difference when you looked at various measures or even thromboembolic events, death rate from any cause, CKD progression, identical between the daprodustat and erythropoietin alpha, which is the current standard of care. So again, that's why there's hope that this drug may actually be one that is ultimately approved for clinical use. Again, this is actually looking at roxadustat, the first one that was, not approved. And again, there was a concern that they didn't meet, during the follow-up, that they didn't quite meet their major adverse cardiovascular outcome to show it was, non-inferior. And that's why that drug was rejected. And then this is roxadustat. On the top line, you're comparing it just to a placebo. So obviously, this drug really nicely corrected the hemoglobin, and it did so both in pre and post non-dialysis dependency. But again, there was a concern about the cardiovascular safety. Again, this is just looking at the first one, roxadustat. The adverse events, there was some evidence of thrombosis, particularly of vascular access, and a slight worse in some of the signals that were looked at with regards to cardiovascular safety. So a lot of this became, a real statistical analysis, and I'm not an expert in that area, but suffice it to say is that the roxadustat was turned down here in the United States. Now, interestingly, this drug is available in some Asian and European countries, and it is approved for use. So it's been quite controversial about these various drugs. The vadadustat, again, not approved. It was found to be quite effective in both correcting the anemia in comparison to the erythropoietin stimulating agents, but it did not meet this non-inferiority criteria for major adverse cardiovascular endpoint. One of the things that's likely to be the case, even if this new agent, the daprodustat, the one that's still viable, if you will, here in the United States, is that if it is approved, that, one will have to talk with the patients, as we do with perhaps any of our therapies, to make it a shared decision-making as to whether to use it or not, as compared to the injection, the erythropoietin stimulating therapy. So again, the concepts here, I think, are familiar to everybody. The idea that we want to have good, effective communications with our patients. We want to be able to describe all the various treatment options. So in this case, if you're talking about anemia, the idea of using an oral prolyl hydroxylase domain inhibitor versus an injectable erythropoietin stimulating agent. And so we want to have a collaborative decision being made in this regard. Just some, again, follow-up of our first lecture that was very nicely done, the importance of discharge planning, nutritional guidance, managing fatigue, obtaining quality sleep, monitoring weight, medication reconciliation, and having good follow-up care. These are all essential things that we need to remember as we discharge patients, something that's familiar to everybody here. Okay, so let's talk about a couple of cases to kind of put this into perspective. So imagine that we have a 68-year-old black woman with stage 4 CKD. In other words, stage 4, remember, is an estimated GFR between 15 and 30. The patient has hypertension. The patient's described as being overweight, and she presents to the emergency department for weakness and shortness of breath over the last 5 days. She states that she has been increasingly fatigued over the last 6 months and has had increasing dyspnea on exertion. Her current medications include an ACE inhibitor and a thiazide diuretic. Okay, so we're told on physical exam her blood pressure is 140/70. Now, if I was managing this patient, I'd like to have a little bit better blood pressure control, and I will argue to you that at stage 4 chronic kidney disease, being on a thiazide's not really effective at that stage of the disease. I'd probably want to make sure she was on a loop diuretic. And if I use furosemide, one of the most commonly used loop diuretics, I always make sure you use it twice a day. Remember, that's a short-acting drug. Lasix, the trade name, stands for last 6 hours. It only lasts 6 hours, Lasix. So you have to use it twice a day. Now, we're told the patient has a respiratory rate of 20, no fever, body weight 150 pounds, BMI 27, no edema. So the question is, why is she weak and why does she have fatigue? Well, we check her labs and the hemoglobin, 9.5, so it's clearly reduced. That could be playing a contributory role. Her potassium's 5.4. One of the advantages of placing that patient on good diuretic therapy is by enhancing the flow and the distal sodium delivery to the latter parts of the nephron, you enhance K secretion. I would argue that that would be a nice way to help correct her hyperkalemia. Her phosphorus is elevated, 6.5, way above goal. We'd want to make sure she's on a phosphate-restricted diet or even consider the use of a phosphate binder. We'd want to normalize that phosphate. Her total bicarbonate, 20. Our goal in management of CKD patients is to have a bicarbonate concentration of at least 22 or above. And again, good diuretic therapy will enhance the bicarbonate regeneration in the distal nephron. A good loop diuretic would be very helpful in this patient for a variety of reasons, helping control the potassium, increasing the bicarbonate. Low-level acidemia that's untreated is a contributor to CKD progression. That's why we like to correct the bicarbonate concentration. So her BUN is 63, her creatinine 3.7, consistent with her stage 4 CKD. Hemoglobin A1C is fine, hematocrit 27%. Now her percent saturation is 24% and her ferritin 120. So I would argue that she's would also benefit from iron replacement. In general, if I see somebody with anemia and their ferritins are less than 200 or their percent saturations are less than 25, that's kind of a threshold that I have to make sure that we consider iron therapy to replete those stores. And then her urinalysis, again, not particularly helpful in this particular case. An albumin to creatinine ratio of 0.8. So that's just kind of how I would describe her. Now, how would you characterize this patient's level of risk for an adverse outcome? Okay, so given all of that data that we just went through, how would you characterize her risk for an adverse outcome? Do you think it's low? Do you think it's moderate? Or do you think it's high? So go ahead and choose one of those answers now. Okay, so most people are saying moderate, but a sizable percentage high. I think, remember, really not a focus necessarily of our discussion here today, but chronic kidney disease is a huge risk for adverse cardiovascular outcomes, independent of any of the things we talked about. In fact, as a nephrologist, when I see somebody with reduced kidney function, while I might want to focus on what I could do to prevent their CKD from progressing, their real cause of mortality is succumbing to an adverse cardiovascular event. And so, it's kind of a nebulous question here in the sense, how would we characterize her risk for adverse outcomes? I think in general, you'd have to describe this individual as having a high risk because this is advanced CKD, and you combine with that the patient's anemia. This patient's really at risk for adverse cardiovascular outcomes. So just kind of consider that in mind. What type of treatment would you prescribe for this patient? So and the choices here are obviously directed towards the anemia, okay? So I talked about some of the other therapies we might employ, but now let's just ask, what type of treatment would you prescribe for this patient regarding the anemia? Would you prescribe an erythropoietin-stimulating agent? Would you prescribe the allyl hydroxylase domain inhibitor, in other words, a HIF-stabilizing agent? Would you give the patient iron, or do you think we should transfuse the patient? So go ahead and choose one of these four choices now. Okay, we got a lot of either iron or PhD inhibitor therapy. So again, I'll be honest with you, those are great choices. So obviously, I think that patient's iron deficient and needs iron. Okay, so we want to do that. But somebody who's not on dialysis, where they come to a unit and we can give EPO through the vein while they're on the machine, that's very easy to do. But an outpatient, to prescribe these ESA agents, a lot of people don't like to give themselves injections. You can certainly, teach people to do that. Some people want to continuously come back to the clinic to get the injection, but there's a lot of logistics. And if we had available an oral once-a-day medicine that could stimulate in a much more physiologic way the EPO production, and also address the underlying disorder in the iron homeostasis, I think that would be very attractive. That's why many nephrologists are very excited about these DUSTATs. We're obviously concerned about the signal for adverse cardiovascular events that occurred with the first two. But this most recent one, doesn't seem to so far have that signal. So we'll have to wait and see whether these drugs are approved or not. Obviously, the transfusion, I think, would be the least attractive, given the fact that there was no real urgent indication to transfuse the patient. And again, hoping that ultimately this patient could get a transplant, we don't want to allosensitize the patient in any way. Okay, how about this 61-year-old Hispanic man? He has stage 5 CKD. So GFR anywhere from 0 to 15. Hypertension, hyperlipidemia. He has type 2 diabetes. He's brought to the emergency department for fatigue and shortness of breath and generalized weakness over the last 3 days. By the way, in anybody with really advanced CKD who presents with weakness, while our focus is kind of on anemia, is there any electrolyte disorder that you're particularly concerned about when somebody presents with weakness? Advanced CKD. Anybody have any thoughts on that? How about hyperkalemia? I always tell our fellows, if you ever get called down to the ER to see a patient with kidney disease and they tell you they are weak, hyperkalemia can present with severe weakness. So that's something to be aware of. His current treatment regimen includes an ACE inhibitor, a statin, a dipeptidyl peptidase, one of the incretins, DPP-4 inhibitors, EPO alpha, he's on EPO alpha, he's on iron sucrose, and we're told he's also on maintenance dialysis. Okay, so he's a dialysis patient. On exam, blood pressure is 145/90, pulse 75, respiratory rate 18, body weight 170 pounds, BMI 29. He has 1+ lower extremity. Now, once you're on dialysis, one of the things we like to do is establish a dry weight. So if I had a patient in whom I'd like to get better blood pressure control, I'm going to prescribe a greater amount of fluid. I'm going to lower their dry weight to try to control their hypertension. Volume is the most important contributor to blood pressures in dialysis patient. The 1+ edema tells me there may be a little bit total body salt overload. Okay, so we go through the labs. Hemoglobin, again, reduced at 9.2. Potassium, 5.0, not terribly high. Phosphorus, 5.4, not too bad, but I'd make sure they're taking their binders, adhering to a phosphate-restricted diet. The bicarb, 24, BUN, 74, creatinine, 9. Very typical of a maintenance dialysis patient. Hemoglobin A1C, 7. And hematocrit, we're told, is normal. And the MCV, 60. So hypochromia, these red blood cells are kind of small. And percent saturation of 25 and a ferritin of 840. Now, in somebody like this, I will just tell you, remember, we use ferritin, right, to assess total body iron stores, but it is an acute phase reactant. And in these people who are receiving dialysis or with advanced CKD, they become inflamed. And sometimes you have to keep that in mind. In other words, this ferritin, 840, you would say, gee, this patient must have massive iron stores. But yet the iron saturation is borderline, 25%. So if the patient was getting an adequate dose of an erythropoietin stimulating agent, I might give a therapeutic trial of some additional iron to see if they might respond, okay? Thinking that inflammation was actually causing the ferritin to be so high. On the other hand, let's see what might be the answer to this question. So, remember, the ferritin's 820, very high. The percent saturation, kind of borderline. The MCV is kind of low, hypochromia. And so what is the most likely cause of the patient's persistent anemia despite erythropoietin stimulating agent? Is it hyporesponsiveness to EPO? Is it an inflammatory process? Or is it iron deficiency? Go ahead and choose one of those now. Okay, so I do think the patient the patient's likely to be inflamed. That's so common in dialysis. There's something about the uremic milieu that leads to high CRPs, a lot of inflammation. If you're inflamed, you're almost always going to be hyporesponsive to EPO. Those all kind of go together. So there could be a component of that. We do need to explain, though, this MCV of 60. I will tell you, I think it's a little, so that at least raises the potential that the patient could be iron deficient. The transferrin saturation was a little bit borderline, and we could explain the high ferritin on the basis of being an acute phase reactant. So it's a little bit, this is a difficult case. But again, one might ask the question, could a PHD inhibitor be useful should this drug class become available? Because again, it could stimulate erythropoietin production, but also contribute to maintenance, better maintenance of iron homeostasis by stimulating the absorption of iron better, lowering these hepcidin levels. That's why, again, a lot of nephrologists are excited about this drug class. So again, kind of a complicated case, I would argue. What changes would you make to the patient's current treatment regimen? Would you increase iron supplementation? Would you increase the ESA dose? Would you switch to a HIF stabilizing therapy, the pro-PHD inhibitor? Or would you transfuse the patient? So go ahead and choose one of those choices now. Okay, so most people want to try a PHD inhibitor. Were it to become available, I think it's certainly something that would be reasonable to try. I'll be honest with you, if I had this patient today, that PHD inhibitor's not, I can't write for it, I would give this patient a therapeutic trial of some iron just to see, there's nothing wrong with giving some more iron. The way we would do that is I would give 100 milligrams. There's a drug called Vinofir, which is kind of standard in our unit, 100 milligrams for 10 consecutive doses, 10 treatments, and see if with my current ESA dose, do I now have correction of the problem, okay? That's kind of what I would do today. If I had the Dustat, I might give it a try because, again, there's a lot of inflammation here, and it's a nice physiologic way to address the anemia that's present. Again, the transfusion, I'm not going to be real excited to do that at this point. So the bottom line is, in summary, anemia is a common complication of CKD that exerts a significant negative impact on patient well-being, work productivity, and health-related quality of life. Patients with CKD-related anemia are at greater risk for poor health outcomes, particularly volume overload and increased hospitalization for mortality. CKD risk is increased among Black, Hispanic, and American Indian individuals. Black patients are more likely to have CKD-related anemia. Better understanding of the pathophysiology of this disorder has led to the development of a new class of agent which exert their effects via stimulation of endogenous EPO production. And in clinical trials, these PHD inhibitors have consistently been shown to be non-inferior to conventional ESAs for hemoglobin correction, either on dialysis or pre-dialysis. And in terms of safety, there are disparate outcomes, including this risk for major adverse cardiovascular event between the roxadustat, the vadadustat, and the one remaining out there, daprodustat. And so studies designed to better characterize the safety are currently ongoing. Maintain a high index of suspicion and apply your diagnostic criteria to all anemia. Evaluate using the appropriate tests that we've went over. Consider all the various causes that may be present, both iron deficiency, inflammation. Give IV iron if oral iron is not being tolerated or is not working, and individualized selection of treatment, taking into account all the patient characteristics. So,
I'll take over.
Okay.
Thanks. Thank you, Dr. Palmer. Great talk. Let's go through some of the polling questions. Please give him a round of applause. Okay. Let's see how you do. A 2022 study by Whitbrot and colleagues found that patients with anemia and CKD at baseline had higher rates of hospitalization. For which of the following cardiovascular events versus patients with CKD without anemia? Was it acute coronary syndrome, heart failure, or stroke? Music, music, music. Well, what do you think, Dr. Palmer?
Good improvement.
Good improvement. Excellent improvement. Any thoughts? Any highlights you want to say, or you're good?
No, I think
Self-explanatory.
I tried to emphasize that during the talk, I think. So maybe that was a little unfair, but yeah.
Good. All right. ESAs, erythropoiesis stimulating agents, and emerging hypoxia inducible factor prolyl hydroxylase inhibitors, HIF-PHI, exert their therapeutic effects by addressing which of the following pathophysiological processes of anemia and CKD? Is it accumulation of uremia toxins, decreased erythropoietin levels, or reduced renal clearance? All right, well, what do you think?
So again, I think everybody got the right answer there. It was even improved. So again, it's just think about this. These inhibiting this enzyme, you're basically creating or mimicking what would occur under conditions of hypoxia, and allowing your normal body's homeostasis to produce the EPO, as opposed to giving these huge doses where you're going to get blood levels very high. High EPO levels, the way we administer it currently, can cause vasoconstriction. For example, it can make blood pressure acutely worse. You're not supposed to give the drug if your patient's blood pressures are high. So again, to be able to cause EPO production in a very slow, graded way is a very attractive physiologic way to treat anemia if we are able to have these drugs available.
Great, thank you. In clinical trials with which HIF-PHI demonstrated cardiovascular safety that was non-inferior to ESAs in patients with either dialysis-dependent CKD or non-dialysis dependent CKD. Is it daprodustat, roxadustat, or vadadustat?
Yeah, so I think a lot of improvement. The daprodustat, again, the roxadustat, the vadadustat, those drugs are approved in other countries. And the signal that they may have had worse outcomes was very soft. There's a lot of statistical analysis that is beyond my expertise, I will just tell you. But obviously the FDA, that was their decision. We'll have to see what they say about this one remaining drug, the daprodustat.
Great, thank you. All right, maybe we'll field a few questions here if that's okay. Great presentation, Dr. Palmer. Given the complexities of the Dustat class, would it be reasonable or preferred to order a nephrology consult mainly to review this new option with those patients who might benefit?
Yeah, I suspect that when the drugs do become available, nephrologists are going to be one of the major prescribers of them, because we see this anemia that's associated with advancing kidney disease. We see it obviously on dialysis. But I suspect ultimately, depending on the comfort of the physician, it could be also used by other clinicians. But I suspect that the nephrologists will be the first ones to use it and perhaps have the best experience.
Great.
Whether it's required to have a consult or not, one could argue.
Any thoughts about the cost? There's another question here about the cost of these medications. Generally, the hurdles exist on the financial side to make these medications available, insurance, Medicare coverage, so forth.
Yeah, no question. I mean, that's obviously a valid question, and it'll be important to see how these drugs are priced. I mean, I have no insight into that at the current time, and obviously, until it's approved, I think we'll have very little information about what that's going to be. But we will have to at least consider the idea that to the extent that these drugs can make us have to forego the necessity of giving IV iron and all the logistics that are involved in that and the resources that are employed, you would have to encompass the cost savings of that particular thing with these drugs. Yeah.
Why Venifer, 100 milligrams for 10 doses, and what is preferred frequency between the infusions?
Yeah, so I was referring to the way I do it in people who are on maintenance hemodialysis. So the patients are coming 3 times per week, and that's just the way we do it. There are strategies, particularly in the outpatient setting, and there are iron formulations where you can give up to 500 milligrams, so 2 doses as an outpatient. So we have done that as well, but to be honest with you, even in our hospital system here at UT Southwestern, it requires patients to come to a clinic that's dedicated to have that all set up. But those iron preparations are available where you can give 500 milligrams as a single dose, very well tolerated. They come back a second time to get the second 500. We usually give a gram in people who are iron deficient. But on the dialysis setting, that's just the way we do it.
Great. Your case 2, would you consider ordering a B12 level?
Yeah, if I recall, the case 2 is one who had the MCV of 60. So, obviously with B12 deficiency or folate, we would expect a high MCV, macrocytosis. So I probably wouldn't have ordered that.
Let's go back to the DUSTAT medications and common adverse reaction side effects.
Okay, so the roxadustat, the one side effect that I was, there was definitely a higher risk for vascular thrombosis. That was a big concern. That's not available. The vadadustat, again, I think there was a similar signal. My recollection with the daprodustat studies is the drug was well tolerated. There was a small number of people who had some gastric erosions that was higher than in the placebo group. Whether that was related to the drug or not, who knows, but it was found in the study, but otherwise well tolerated. Yeah.
Here's a question from the LTAC setting, but it probably applies broadly. They have a lot of dialysis patients who receive ESA and iron supplementation. They get frequent lab draws, but never get a hemoglobin above 10. Do you still continue the ESA? So if the hemoglobin doesn't go above 10, what do you do with the ESA?
We assuming that they had started at a lower value and you've now gotten them up to 10, I would still continue to do it, but continue to explore, is there some reason that they're not responding further?
And what happens if they go above 10?
Then we obviously hold.
So the goal is 10?
Well, 11 to 12 is kind of where we try to get our dialysis patients. But, sometimes if I can get it above 10, I feel reasonably happy about that. Yeah. So, sometimes people who have a subclinical infection of an old access that's not being used can be a source of ongoing inflammation that's readily correctable. Any kind of, you search for a cause of inflammation when people aren't responding and you think that they are iron replete. You search for, is there some sort of source of inflammation that is going on?
Now the other side of, just so that we are complete, the reason, what if people are at 12 or 13? Is there a role for ESA?
Well, if they're 12 or 13, I'm happy with those values,
And the risk for thrombosis goes up, right?
Yes. So remember, in those major trials, it surprised a lot of people that if you try to correct beyond 12 or once you get to 13 and above, higher risk of stroke, cardiovascular events.
Yep.
So we don't do that.
Here's a question about managing IBD patients with CKD anemia. What do we need to know about patients with chronic inflammatory disease and the impact on kidneys and/or anemia?
IBD, inflammatory bowel disease?
Inflammatory bowel disease.
Again, I don't have a lot of personal experience in that, but that would be, again, presumably a patient population that would be difficult to treat should they have anemia. Number one, they probably have some ongoing blood loss. They're obviously inflamed. I'm not aware of any contraindication from using erythropoietin-stimulating therapies, but you'd have to make sure and be aggressive about iron supplementation, and presumably they would require higher doses. That would be my prediction, at least.
Dose range for ESA, how high can we go safely? I think we covered that. What are your thoughts? Oh, well, I think they're talking about the dose range. So what's the highest dose you can go to for ESA?
You know, a typical dose we might use is 2,000 to 3,000 units in a dialysis setting, 2,000 to 3,000 units every treatment. In the outpatient setting, we can use it once every 2 weeks, and sometimes once a month. You kind of titrate it according to what the patient might need. So, but you can use doses up to 10 and 12,000, but those are usually people that are hypo-responders because of inflammation and the like. So if you're asking for a range, 2,000 all the way up to 10 to 12,000, frequency is going to be widely variable in the pre-dialysis population.
Great. What are your thoughts what are your thoughts on how some hospitals have a policy to help with cost savings only to start a patient on ESA, such as Retracrit, only after 7 days of hospitalization and/or until 7 days from their last outpatient ESA dose? Emergent patients needing this, of course, can start immediately in the ER.
Yeah, so again, I think this goes back to this communication. I mean, a lot of times we may give a single dose while a patient is hospitalized. Maybe I'm seeing a patient with CKD for the first time, and I think they probably would benefit from being on it chronically. We have to make sure that that communication is done so that the patient can get subsequent doses. Usually, if I've started it for the first time, waiting a week or even 2 weeks is no problem to get the next dosing. But the problem is we need to make sure that the patient is scheduled to get those subsequent doses. And so I think that goes back to the points that you raised, the necessity of communication to the outpatient doctors.
Great. Yeah. Thank you, Dr. Palmer. Any other questions here? All right. Dr. Palmer, thank you. Excellent talk. I'm going to answer a couple of questions that came up afterwards during my session. What types of IT systems, chat function, and Epic or two-way paging system can be put in place to help with communication? So, what we use at our institution is something called Tiger Text, and it's a secure system that allows you to text back and forth. Epic Chat also, as an example, is another chat function that allows you to chat back and forth that is inside the electronic medical record. So there's a number of systems out there that allow